Anaphylaxis is a severe, potentially life-threatening allergic reaction. Anaphylaxis is likely if a person exposed to an allergen develops systemic changes which affect the skin, respiration and circulation, and which usually progress over several minutes. After being exposed to a substance such as bee sting venom, the person's immune system becomes sensitized to it. When the person is exposed to that allergen again, an allergic reaction may occur. Anaphylaxis happens quickly after the exposure. The condition is severe and involves the whole body. Most episodes of anaphylaxis are triggered through an immunologic mechanism involving immunoglobulin E. Subsequent exposure to the antigen causes mast cells to degranulate, releasing inflammatory mediators histamine that promote bronchoconstriction, vasodilation, and inflammation. Although any substance has the potential to cause anaphylaxis, the most common causes of immunoglobulin E-mediated anaphylaxis are foods. The most commons are particularly peanuts, tree nuts, shellfish and fish, cow's milk and eggs. And also there are medications, most commonly some non-steroidal anti-inflammatory drugs and antibiotics, that triggers anaphylaxis. Other causes are stinging insects can also cause anaphylaxis, and in other cases the cause is unknown yet. In children, anaphylaxis is most often caused by foods, while venom and drug-induced anaphylaxis is more common in adults. There are less common causes of anaphylaxis that are rare to be seen. This includes exercise, hormonal changes, menstrual factors, and lastly, transfusions, which occurs when immunoglobulin E antibody in the patient interacts with an allergen. Tissues in different parts of the body release histamine and other substances. This causes the airways to tighten and leads to other symptoms. But in some people, the reaction is more severe. Symptoms include swelling, wheezing, shortness of breath and difficulty swallowing. An anaphylactic reaction affects several areas of the body at once. In skin, there are symptoms like urticaria, angioedema, erythema, or as flushing, itching and eczema. Respiratory system. In upper airway there are nasal congestion, sneezing, hoarseness, cough and laryngeal edema. In lower airway of the respiratory system there are dyspnea, cough, bronchospasm, wheezing and chest tightness. Cardiovascular system symptoms are hypotension, dizziness, syncope and tachycardia. In gastrointestinal system, nausea, vomiting, abdominal pain, diarrhea, are the main symptoms. In neurologic system, lightheadedness, dizziness and confusion mainly occurs. In oropharyngeal, pruritus, tingling and angioedema occurs. And lastly, other symptoms include sense of impending doom and anxiety. Patients also often describe an impending sense of death. Death due to anaphylaxis usually occurs as a result of respiratory obstruction or cardiovascular collapse, or both. It is important to note that the signs and symptoms of anaphylaxis are unpredictable and may vary from patient to patient and from one reaction to another. Therefore, the absence of one or more of the common symptoms does not rule out anaphylaxis, and should not delay immediate treatment. The acute treatment of anaphylaxis. The acute treatment of anaphylaxis begins with a rapid assessment of airway, breathing and circulation, followed by the immediate administration of epinephrine. Epinephrine is the drug of choice for anaphylaxis and should be given immediately to any patient with suspected anaphylaxis. Treatment should be provided even if the diagnosis is uncertain, since there is no contraindication to the use of epinephrine. The recommended dose of epinephrine for anaphylaxis is 0.01 mg per kilogram, with the maximum of 0.5 mg administered intramuscularly every 5 up to 15 minutes as necessary. Intramuscular administration into the anterolateral thigh is recommended as it allows for more rapid absorption and higher plasma epinephrine levels compared to subcutaneous or intramuscular administration in the upper arm. And in addition, glucagon should also be considered in patients using beta blockers. All patients receiving emergency epinephrine must be transported to hospital immediately for evaluation and observation. Ideally, patients should be placed in a supine position, unless the respiratory compromise contraindicates it, to prevent or to counteract potential circulatory collapse. Pregnant patients should be placed on their left side. Once supine, patients should not be allowed to sit up until clearly fully stabilized, owing to the risk of empty ventricle syndrome, which can precipitate a profound loss of blood pressure and death. As mentioned earlier, patients with asthma, particularly those with poorly controlled asthma, are at increased risk of a fatal reaction. In these patients, anaphylaxis may be mistaken for an asthma exacerbation and inappropriately treated solely with asthma inhalers. Therefore, if there are ongoing asthma symptoms in an individual with known anaphylaxis, epinephrine should be given. Oxygen therapy should also be considered in any patient with symptoms of anaphylaxis, particularly for those with prolonged reactions. Intravenous crystalloid solutions should also be provided since massive fluid shifts can occur rapidly in anaphylaxis due to increased vascular permeability. Volume replacement is particularly important for patients who have persistent hypotension despite epinephrine injections. Vasopressors, such as dopamine, can also be considered if epinephrine injections and volume expansion with intravenous fluids fail to alleviate hypotension. If anaphylaxis fails to respond to intramuscular epinephrine and intravenous fluids, an intravenous infusion of epinephrine may be required. However, these infusions should be given by a physician who is trained and experienced in its use and has the capacity for continuous blood pressure and cardiac monitoring. Patient teachings to be considered. People with potentially serious allergies are often prescribed adrenaline autoinjectors to carry at all times. These can help stop an anaphylactic reaction becoming life-threatening. Adrenaline autoinjectors are automatic injector devices for emergency first aid treatment of anaphylaxis. They contain a single fixed dose of adrenaline. They are designed for self-injection, and should be injected into the outer mid-thigh muscle and can be administered through a single layer of clothing. Also, another patient teaching is about correct positioning of the patient. Someone experiencing anaphylaxis should be placed in the correct position. Most people should lie flat with their legs raised. If they're pregnant, they should lie on their left side. People having trouble breathing should sit up for a short time to help make breathing easier, and then lie down again when possible. And lastly, avoid a sudden change to an upright posture such as standing or sitting up. This can cause a dangerous fall in blood pressure. Identify and avoid triggers. Finding out if you're allergic to anything, whether it's any kind of food that could trigger anaphylaxis, can help you avoid these triggers in the future. If you're allergic to certain types of medicines, there are normally alternatives that can be safely used. For example, if you're allergic to, let's say, penicillin, you can normally safely take a different group of antibiotics known as macrolides. For nonsteroidal anti-inflammatory drugs, such as ibuprofen and aspirin, you can normally safely take paracetamol, and always tell any healthcare professional about medicine allergies you have, as they may not be aware of them.